go ahead.
Thank you, and welcome to all of you. My name is Jesse Milan. I'm President and CEO at AIDS United, and I'd like to welcome you to today's webinar sponsored by the Syringe Access Fund. The Syringe Access Fund is a national grant-making collaborative supported by the Elton John AIDS Foundation, the Henry Van Ambergen Foundation, the Irene Diamond Fund, Levi Strauss Foundation, the Open Society Foundations, and AIDS United. We know that the opioid and HIV epidemics are two of the most pressing public health challenges of our time, and they are increasingly intertwined. 1 in 10 new HIV diagnoses arise in people who inject drugs. Meanwhile, despite the availability of a cure, hepatitis C now kills more Americans than all 60 other nationally notifiable infectious diseases combined. While plenty of attention has been paid to the opioid epidemic, and in some cases harm reduction as it relates to overdose deaths, very little has been written about the infectious disease consequences of this latest crisis. We've seen alarming increases in hepatitis C and HIV cases in injection drug users, particularly in rural areas, which are consistent with the same trends in opioid misuse. Today, our fantastic expert panel will discuss our findings from evaluation data collected from our last round of Syringe Access Fund grantees and feature 3 grantees' accounts of the trends they're seeing on the ground. We thank you again for joining us today, and with that, welcome to all of you, and we'll turn it over now to our staff at AIDS United.
Thanks, Jesse. My name is Kyle Murphy. I'm Communications Director here at AIDS United. I'd like to reiterate our appreciation for joining today's telebriefing. We're excited to share some of the trends we've identified during our latest round of Syringe Access Fund grants. But first, we have Nora Fuller, our Syringe Access Policy Organizer, to provide some background on the state of the nation's opioid crisis and infectious diseases. Nora?
Hello. So before we get into the specific data of the round 9, I wanted to share some background from the epidemiological aspects of the syringe service program. So first we have to talk about, of course, the most pressing issue, which would be the huge amount of lives lost to drug overdose. We've seen increases with opioids and heroin accounting for 72,000 lives lost in 2017. 49,000 of those were from opioid related. And then we've also seen increases in deaths involving drugs like cocaine and benzodiazepines. So from 2002 to 2016, there was an 8-fold increase in the total number of deaths involving benzos, and deaths involving both cocaine and opioids have more than tripled since 2010, while cocaine deaths not involving opioids have increased 1.5-fold. Syringe services programs play an outsized role in addressing the overdose crisis by providing naloxone, the opioid overdose antidote, directly to laypersons who use drugs. In this map, you can see the spread of overdose prevention programs across the country through June 2014. From 1996 through June 2014, surveyed organizations provided naloxone kits to 152,283 laypersons and received reports of 26,463 overdose reversals. The reported number of organizations providing overdose prevention kits with naloxone almost doubled from January 2013 through June 2014. The National Survey of Drug Use and Health in 2017 found that among Americans 12 and over, 11.4 million reported opioid use in the past year, and 2.1 million, or 14%, met the diagnostic criteria for an opioid use disorder. Please note the staggering proportion that do not qualify for substance use treatment programs, but remain vulnerable to the negative consequences of drug use. That's 86%. Not all those who use drugs and are at risk of overdose are injectors, but injecting drugs comes with increased overdose risk as well as increasing vulnerability to bloodborne pathogens and the risk of infectious disease transmission, including HIV and viral hepatitis. There are an estimated 6.6 million Americans who have injected drugs in their lifetime, with 775,000 who have injected in the past year. The CDC determined that people who inject drugs accounted for 9% of HIV diagnoses in the U.S. And a report in the Open AIDS Journal found that less than half of people who inject drugs were retained in care or reach viral suppression. People who inject drugs also account for approximately 68% of new hepatitis C infections, an epidemic in which new cases have grown 350% since 2010. Like Jesse said, hepatitis C is now responsible for more deaths than HIV and every other of the 60 nationally notifiable infectious diseases combined. Research shows that among people who inject drugs, 64% are chronically infected with hepatitis C. Perhaps most alarming, about 80% of people who use drugs who are living with HIV also have hepatitis C. HIV and hepatitis C co-infection more than triples the risk that an individual will suffer from liver disease, liver failure, and liver-related death. Use of syringe services programs among people who inject drugs has increased substantially during the past decade. In this map, you can see the growth of new syringe service programs in the Ohio River Valley, but we've also seen it in places that have had these programs for 20-plus years. However, increasing trends in drug injection in suburban and rural areas where HIV and hepatitis C prevention programs and services are often lacking has been correlated to outbreaks of HIV and hepatitis C. Most noted is the outbreak of HIV in Scott County, Indiana. At the time, syringe exchange was illegal in the state of Indiana. A recent Lancet study used modeling to determine whether earlier implementation of a public health response could have reduced the scale of the outbreak. It found that if a public health response was initiated in 2013, it could have suppressed the number of infections to 56 or fewer, averting at least 127 HIV infections, whereas an intervention in 2011 could have reduced the number of HIV infections to 10 or fewer, averting at least 173 infections. The CDC identified 220 counties that resemble Scott County and are most vulnerable to outbreaks of HCV and HIV related to injection drug use. These counties are spread across 26 states and represent only 5% of counties vulnerable to outbreaks overall. Currently, over 90% of those 220 counties vulnerable to HIV and hepatitis C outbreaks do not have comprehensive syringe services programs. 20 of them do. Young people aged 20 to 29 years in non-urban areas represent a growing population of people who inject drugs and the infectious disease consequences of injecting. An analysis of young people living with hepatitis C infection found that only 1 in 5 lives within 10 miles of a syringe services program. In response to this public health catastrophe, syringe services have been eventually legalized in increasing numbers of states and jurisdictions, and the ban on federal funds for syringe exchange programs was partially lifted. The Longitudinal National Survey of Syringe Exchange Programs from Don Desjardins and the North American Syringe Exchange Network provides the following information. There were 68 syringe exchange programs known to be operating in the United States in 1995, and 186 in 2007, and then 204 in 2013. There are approximately 125 more now, with a total of 329 since October 2018. The West and Northeast had the highest number of syringe services programs, and the South had the lowest. The South also bears the brunt of the nation's HIV epidemic. The number of syringes exchanged has increased, but budgets of syringe exchange programs have not kept up the pace. Surveys from 1994 and 2000 found that half of all syringe exchange programs received state and local government funding, and among those that received state and local government funding, it accounted for a mean of 87% of the budget for syringe exchange services. Receiving state and local government funding was associated with larger numbers of syringes exchanged per year, providing more on-site services and better performance. In the most recent survey from 2013, state and local funding accounted for 78% of syringe exchange funding, while private grants filled the gap. Importantly, these surveys were conducted before syringe services programs could receive any federal funding. The ban on federal funding was partially lifted in 2016. Under the Consolidated Appropriations Act of 2016, federal law now permits the use of funds from the Department of Health and Human Services to support syringe access, with the exception that funds may not be used to purchase syringes or cookers. In order to use these funds for this purpose, health departments must first consult with the Centers for Disease Control and Prevention and provide evidence that their jurisdiction is experiencing or at risk for significant increases in hepatitis infections or an HIV outbreak due to injection drug use. So far, 35 states and D.C., 1 territory, 7 counties, and 1 city received a determination of need as of September 11, 2018. But the barriers to accessing federal funds are high. Agencies already receiving funding were allowed to repurpose funding towards supporting their syringe services programs, but no new funds were made available. HIV prevention funding has remained flat, and hepatitis programs experienced a small $5 million bump for this year. While opioid crisis response funding has been made available to the Centers for Injury Prevention at the CDC and to SAMHSA's state agencies, it has generally remained inaccessible to most syringe services programs. Models of hypothetical increases in funding found that investments in syringe services would result in hundreds of HIV infections averted and millions of dollars in treatment costs avoided. Instead, the ban on federal funding had a chilling effect on the expansion of syringe services programs, and it's still being felt today. As early as July 1991, the National Commission on AIDS prepared a report for the federal government that outlined the relationship between the AIDS epidemic and substance use, stating, quote, "The federal government strategy of interdiction and increased prison sentences has done nothing to change the stark statistics. Despite this insidious and indisputable link between substance use and HIV infection, the Office of National Drug Control Policy continues to virtually ignore it and neglects the real public health and treatment measures which could and must be taken to halt the spread. In the nearly 3 decades since publishing this report, the federal government continues to place the burden on private philanthropy and tight state and local government budgets to support syringe services programs and refuses to allow federal dollars to be spent on syringes and injection equipment." Thank you.
Thanks, Nora. And next up, we have our program manager, Zach Ford, provide an overview of the Syringe Access Fund and our Round 9 report. Zach?
Hello, everyone, and thank you so much for joining us this afternoon. My name is Zach Ford. I'm a program manager on the Syringe Access Fund at AIDS United. During the Round 9 funding cycle, AIDS United awarded syringe services grants to 51 organizations and policy and advocacy grants to 7. The grantee cohort was comprised of organizations from 31 states, the District of Columbia, Puerto Rico, and the U.S. Virgin Islands. Grantees exchanged over 65 million syringes and worked with nearly 200,000 unduplicated participants. Our grantees introduced 19 syringe access bills in 12 states, with 7 laws passing in 6 states. 11 overdose prevention-related bills were introduced in 8 states, and 8 were passed in 6 states. Our grantees report on demographic data. However, not all of them require participants to respond to demographic questions, and so there is a significant number of unknown data across all demographic categories. In the data that was reported, however, it showed that the majority of participants identify as white and non-Hispanic, majority male, and majority between the ages of 25 and 34. Our data shows that 3,854 participants self-reported as living with HIV, and 16,596 self-reported as living with hepatitis C. A common narrative was identified across reports, with grantees noting an increase in participants along with increases in overdose rates. At the same time, the number of startup syringe services programs is increasing, creating greater competition for already limited funding. The ban on federal funding for syringe services programs was partially lifted in 2016. However, syringe services programs still may not use federal funds to purchase syringes or cookers. Private funders have shifted grant dollars due to the partial lift of the federal ban, and grantees report reduced funding from both the public and private sectors. Reduced funding has led to a decrease in the number of staff members syringe services programs can afford to pay, a decrease in program hours of operation, and a decrease in the number of supplies they can afford to purchase. The CDC estimates that 72,000 people died from drug overdose in 2017. Syringe services programs are experiencing high demand for overdose prevention at the same time that funding is being reduced. Due to a drug supply that is saturated with fentanyl, organizations report having to allocate already limited funding to purchasing additional supplies such as naloxone and fentanyl test strips. One grantee reported losing 192 program participants to fatal overdose during the 2-year reporting period, despite distributing more than 2,300 doses of naloxone. While organizations operate with limited funds and increasing rates of fatal overdose, they also work within an increasingly hostile political environment. Many grantees report that their cities are targeting people experiencing homelessness. Multiple grantees report law enforcement and city officials closing well-known shooting galleries and passing urban camping bans. This anti-homeless sentiment leads to the displacement of Syringe Services Programs participants, creating hardship on program staff when attempting to reach participants and provide services. When participants move to new areas, they may no longer be able to access drop-in services, mobile exchanges may not know where to find them, and services may not exist in the new area. These factors have led to negative consequences. Grantees report having to go against best practices because of a lack of funding and place a cap on the number of syringes each participant collects, creating a situation that could increase the likelihood of syringe sharing. Staff are spending less time with participants, removing the relationship-building aspect, a crucial component for access and linkage to care. Community demographics are rapidly shifting in urban areas around the country, with young, upwardly mobile individuals moving into neighborhoods that have been occupied for decades by people who use drugs. As the community changes from low income to affluent, syringe services programs are being forced out, along with program participants. Grantees also report spending less time and money on testing for HIV, viral hepatitis, and sexually transmitted infections because of limited funding and staff. This has all led to increased rates of HIV and hepatitis C, less safe injecting, such as syringe sharing and public injecting, and increased rates of fatal overdose. Under the Consolidated Appropriations Act of 2016, the federal funding for syringe services programs was partially lifted. The syringe, however, is the tool of engagement that syringe services programs use to reach people who use drugs. Providing a sterile syringe not only prevents the spread of infectious disease, but also provides an opportunity to build trust and share information, resources, and referrals. Not allowing organizations to use federal dollars to purchase syringes is directly contributing to the increasing rates of HIV, hepatitis C, and fatal overdose that we are seeing across the country. Syringe services programs are proven and effective when it comes to preventing infectious disease. All one has to do is look at Scott County, Indiana, to see the impact these programs can have on a community. In 2017, AIDS United released the RFP for the Syringe Access Fund Round 10. We received $12 million in funding requests from syringe services programs around the country, yet only had $2 million available. The Syringe Access Fund cannot continue to operate unless other private funders contribute, and the federal government stops expecting and requiring private philanthropy to do its job. Private philanthropists and foundations need to contribute funding to the Syringe Access Fund. The newly elected Democratic-controlled House needs to fully lift the ban on federal funding for syringe services programs. These two things do not happen, rates of HIV and hepatitis C will continue to rise, and more lives will be lost. So that is all on my section. Up next, we have Charles King, President and CEO of Housing Works.
Good afternoon, everyone. I just want to give you a little bit of background and bring folk up to date with where Syringe Exchange is in New York State. Just a little bit of history. Syringe Exchange began in New York State in the late 80s, largely as underground illegal programs. ACT UP New York in 1989. Actually 1990, decided to do an act of civil disobedience, publicly advertising a syringe exchange and using that to force an encounter with the police in which they were arrested, charged with misdemeanors, and then went to trial. They were prosecuted by the district attorney. They argued necessity, and the judge ruled in favor of the defendants on the grounds of necessity, forcing New York State to develop one of the first official protocols around syringe exchange anywhere in the country. Today, there are 23 organizations that hold waivers to distribute syringes, and they distribute them through more than 70 sites throughout New York State. It is the most extensive network of syringe exchange programs anywhere in the United States. Just to give you a little sense of the impact of what has happened here in New York, in 1995, at the peak of the AIDS epidemic, we were facing 15,000 new cases of diagnosed HIV every year, and of that 15,000, one half, 7,500, were among people who inject drugs. As of 2016, which is the last year for which we have official surveillance data, there were only 116 cases of new diagnoses of HIV among people who inject drugs, and frankly, we believe that the overwhelming majority of those cases were related to sexual transmission as opposed to transmission associated with injection drug use. So I think that speaks very powerfully to the success of syringe exchanges in addressing an important public health crisis. But the other thing that I think is important to note is that when a jurisdiction embraces syringe exchange, it opens the door to many possibilities. So shortly after we began offering syringe exchange, various of the programs began bolstering their services with other types of harm reduction services, including counseling, support groups, activities that moved people towards contemplation of treatment, motivating people to consider reducing their use of drugs, changing their use of drugs, modifying their behaviors, becoming more independent. This last July, New York State became the first state to implement harm reduction counseling and services that are reimbursed through Medicaid, through a waiver that was approved by CMS. So we're really proud of having achieved that remarkable milestone of getting harm reduction services associated with syringe exchange seen as a reimbursable healthcare intervention. We're now developing 8 of our syringe exchanges to be health hubs that provide hepatitis C testing and treatment, that provide HIV testing and can refer people for treatment or put people on pre-exposure prophylaxis, and that can also prescribe buprenorphine to people. And in fact, later this month, Housing Works will be opening the first primary care center embedded in a syringe exchange program. We're piloting a model for which our State Department of Health is issuing a guidance that will allow basic primary care to be offered in any syringe exchange program in New York State, turning these into something more than just a place where you go to get clean needles and other paraphernalia associated with injection drug use, but as hubs where people can go to receive comprehensive health and wellness services specifically designed for people who use drugs, people who inject drugs. In addition, we will be rolling out in the next 6 months a new set of regulations that will allow a second tier of exchange, basically allowing any church, any local government entity, including a fire department or public health agency, to provide and collect syringes for people so that we can offer syringe exchange in even our most rural counties here in New York State. So we're quite proud of the fact that we're pioneering the way, and we want to show what syringe exchange can become once we reimagine and think not just about preventing disease transmission, but turning these into locations that really become the center of health and wellness for people who are using drugs. And I'll stop with that.
Thank you so much, Charles. Next up, we have Dr. Hansel Tooks an assistant professor of clinical medicine in the Division of Infectious Diseases at the University of Miami Miller School of Medicine. He also helps run the Miami Idea Exchange. Hansel?
Thank you so much. It was very nice to hear Charles speak about the work that they were doing in the 1980s in New York City. So I will bring you to Florida, which is present-day 1980s New York City. And in 2016, we were finally able to authorize a pilot syringe exchange program here in Miami. Now, we are fortunate enough to have won the Syringe Access Fund grant 3 times. The first year that we attempted to pass syringe exchange legislation in Florida was 2012. The context of the situation was that Miami has the highest rate of HIV in the entire country, 4 times the national average, and we had a basic lack of access to bread and butter public health. We were able to identify syringe exchange as one of the ways that we could combat HIV infections in our city very easily based on the evidence out of places like New York. And this was at the same time as the Florida legislature was closing the pill mills, which in many ways fueled the modern-day opioid epidemic that we see in the South and on the East Coast of the United States. So at that time, we filed legislation in order to try to authorize syringe exchange here in Florida. Of course, the first year, everybody told us that we were crazy, that this was never going to happen in Florida. But we were able to start getting allies in the medical community and also in the community of people who were using drugs. In the second year that we filed legislation, we were fortunate enough to have a Syringe Access Fund grant. And the reason that was so important for us is because we're in Miami and Florida is governed by a small town in the north called Tallahassee. And we had to be able to get there. We had to be able to fly people who use drugs, medical students, mothers. We had to be able to get people to Tallahassee to let the legislators know that this work was important and this work was essential to our state in terms of saving lives and preventing HIV infection. So when we won the Syringe Access Fund the first time, we were really able to better organize our coalition and get people to the Capitol. In that year, since we were able to be such a present force, we almost passed the expansion legislation. So 2016 was when we were finally able to get the bill through. Of course, it was a compromise, but on top, in addition to having the funds from the Syringe Access Fund, we were able to consult with the Syringe Access Fund at all times and organize with them on how we were going to strategize to get this legislation passed. That was very important because there was no infrastructure for this here in Florida. So we were able to pass the legislation back in 2016, and we were able to open up our first needle exchange program. Now, the success of our program has been, astounding. The rate of overdoses in Miami have dropped by 39% since we started handing out naloxone. We recently identified a cluster of HIV infections. We were actually able to control and end the transmission of HIV through early detection, linkage to care, and assistance with adherence to medication. Now, in the absence of the program that we were able to establish through the advocacy under the Syringe Access Fund, in the absence of our program, we can imagine that what would have happened in Miami, which is the city that already has the highest rate of HIV infections, would have been of epidemic proportions. So it's been a really challenging course here in Florida. We have a very hostile political environment, but if Florida can have a syringe exchange program, we're very confident that we can use this roadmap, which is different than the roadmap that they had in the more progressive cities back in the 80s, but we can use this roadmap for these late adopter states to assist other states in the South in moving forward with harm reduction practices. And that's one thing that we've been doing, is we've been consulting with other states, working with medical students in Georgia, and we're really looking forward to helping them with getting syringe exchange as well. Now, it's very, very difficult to discuss with the press the fact that there was a cluster when our program already existed, but it's very these infections would never have been detected if our program didn't exist, and so it's really important that people realize that one of the main functions of the syringe exchange program is to test people and help them get into care. And we have been able to do that only because we were able to get this legislation passed for Miami. So we're filing legislation again for statewide expansion. All of the legislators pretty much agree that our pilot program has been a success. So we're really looking forward to expansion in the rest of the state. And Florida has one of the most complicated political systems, I think. Well, you all know that now because we're under a recount. So, you know, I really feel that when Florida falls and we're able to get syringe access statewide, it's going to be a harbinger for what's good to come in the entire South. And that work is because of what we've been able to do with the Syringe Access Fund. So that's, I'll leave it at that.
Thank you so much, Hansel. So next up, we have Luis Vincent, the Executive Director of the Greensboro Exchange and North Carolina chapter of the Urban Survivors Union. Luis?
Yes, hello. My name is Luis Vincent, and I'm the Director of Urban Survivors Union. And we are a slightly different model of organization. We're a community-led organization, which means that former and active drug users, people with lived experience, are involved in every way in our program. We started out long before syringe exchange was legal, really just being people who use drugs, helping people get naloxone and syringes. And, you know, it really wasn't much. It was just us running around providing the people and our friends with and loved ones with life-saving services. And we didn't really even call it any didn't have much of a name. And over the years, we grew and we started working with a group called North Carolina Harm Reduction Coalition. And North Carolina Harm Reduction Coalition really saw fit to help build what we call a drug user union and a community-led group. And this did a number of things and continues to do these things. By working with people that use drugs, we are able to provide relevant information and, you know, what's going on right now to other groups and to our own group. We ensure we're also able to create a culture of understanding and just a different atmosphere than often you get from top-down approaches. What we see is through the community organizing and through the trust that we have with the community that we work with, we are really able to reach people and in a way that you don't see happen in other settings, or at least it doesn't happen quickly. So very quickly we were able to, you know, once we had funding from Syringe Access Fund, we went from this sort of a group that was just providing syringes and the most basic services to having a space to have and being able to have people come to our space, have groups, really and really be able to see what was possible when you're able to really connect with people that use drugs. And this is what's so cool is things happened that we didn't expect. That the research talks about it. But it was really amazing to be part of it. So all of a sudden, people that use drugs have had a place in an organization, and they had a job to do, and they had an importance. And so we see people coming in as passive recipients of service and staying as active service providers, which is very much my story. And staying as active service providers and going on and getting college degrees and doing these things because we fall in love with the work. And that's not every story, but so many people are able to find hope, and it is truly beautiful in so many ways that you almost can't see unless you really go and experience some of this. But we do know that from working with other groups, how important it is for drug users to be involved in every level of service provision. And so at the Greensboro Exchange, that's what we've been able to do, and we now are able to provide hepatitis C testing and HIV testing, and in fact, we are the group, the numbers of people we're seeing are growing, and we are connected with different communities that we are just really thrilled that it's possible. Women's programs, women's specific programs, which are so important because people that have experienced this are leading the way, and we've been entrusted with this important task. You just see connections made and a level of trust that is really, it's allowed us to do research with research organizations that I don't think would have happened prior, and in other organizations, because we have this kind of trust with the community, and people involved in national organizing and really being and caring about their health, and having for the first time the real ability to take care of their health. And one of the really cool things that we see now is because syringe exchange legalization just passed in 2016, so people still remember very much what it was not to have services. And some people are still just now finding us, right? But the level of gratitude and just because we have this message, that society tells one another that drug users don't care about their health. Well, it's hard to really be invested in your health when you can't even access sterile supplies. And so what we see is people who very much care about their health that now have a conduit. They now have somebody to talk to. They now have a trusted community that they can come to us, and we can help them find their way to treatment if that's what they want, to the hospital for endocarditis and infections and all of the things that we're seeing. They have trusted folks that care about them, and so they're able to share about these things. We see a level of honesty that, frankly, I've worked in traditional treatment settings for a long time, and the level of honesty we're able to see and really deal with is unmatched. And we are truly grateful. This is all due to Syringe Access Fund and other funders who have believed in this and really understand the importance of having drug users involved in service provision and know the importance of centering the experiences of people that use drugs. And this is, sort of the basis of harm reduction. And it's so important that these things don't get lost. And I am truly grateful, and our participants are truly grateful that they get to be the organization that they want, that they get to feed and participate in that. And I just, it's just been a real opportunity that's really been wonderful. And so we appreciate it. Thank you.
Thanks so much, Louise. And operator, I think we're ready to open up the questions. If there are any questions from folks on the call.
Thank you. If you'd like to ask a question, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open, so please state your name before posing your question. Again, press *1 to ask a question, and we will pause for just a moment to allow everyone an opportunity to signal for questions. And we have no questions at this time. You may continue.
So if there are no questions, I think we'll just close stuff up. Thank you so much for calling. We really appreciate it, for participating. If you want additional information on SAF or any of the programs that were highlighted on today's call, you can do so on our website at aidsunited.org/SAF, SAF. Also, you can email us any questions you might have at saf@aidsunited.org. Thanks so much, everybody, and have a great afternoon.
This concludes today's call. We thank you for your participation. You may now disconnect your lines and have a wonderful day, everyone.